Going to start off with another combined talk, and it's going to be with Dr. DeWitt. Elizabeth DeWitt is an interventional electrophysiologist at Boston Children's. She's the medical director of the surgical EP service and the associate fellowship director. She has research interests including intraoperative EP mapping and arrhythmia syndromes. And Dr. Eric Feins is one of the pediatric cardiac surgeons. He's a surgical director of the surgical EP program and also part of the Complex Biventricular Repair Program. And his research interests include device development, pediatric heart valve mapping, and intraoperative conduction mapping. And they're going to share with you about our intraoperative conduction mapping program.
Thank you so much, and thanks for the opportunity to present some of the stuff we've been working on here this evening. So I won't dive into all the details of conduction anatomy and heterotaxy syndrome because I'm not sure we have time for that, but briefly, we know a fair bit about where we might anticipate conduction anatomy to be located in the different forms of heterotaxy. There's been a lot of work over the years from different groups of cardiac anatomists and pathologists that have done painstaking and beautiful research articles demonstrating where the individual conduction system has been located in certain patients. And this is one such example from 1992 in Jack, looking at 14 patients with heterotaxy and comparing them to normals or normal anatomy patients who had heart block, and demonstrating one by one what their conduction looked like, their AV nodes and the interruption or connection to different structures. And this group and those within it, have demonstrated further in a larger cohort. This was 35 patients with heterotaxy, looking at demonstrating all of these different hearts, trying to group them in categories based on their anatomy of their atria and their venous connections, their isomerism, whether they're left or right atrial isomerism, and then detailing out all of their different AV conduction abnormalities. And what we see is that in every effort to make sort of groupings of these patients and to try to standardize where we might expect the conduction system to be and exactly what the connections are within the heart, while you can make some characterizations of this, you can't fully understand exactly. There's still a fair amount of variability in those hearts, even as you try to kind of group them together. And perhaps this is one of the reasons that the reported literature on the rates of heart block and heterotaxy patients remains relatively high when we try to operate on these patients. This is a report published in 2015 that detailed 20 heterotaxy patients who had biventricular repair, and fully 25% of them required pacemaker implantation for postoperative heart block. Not an optimal outcome. At our own institution, our historical norms for this were published, and with these 91 patients, 14% required a pacemaker implantation historically for postoperative heart block. So we asked ourselves, as we were continuing to sort of face this earlier on, why haven't we found out what we're looking for? Why haven't we been able to translate the pathological understanding, the anatomic understanding to what happens in the operating room and avoid heart block right there and then? I think there are a couple of different potential reasons for this. One is that will always be limitations to relying on studies based on a finite number of hearts to create rules for a group and for an individual patient. And we know how much variability there is in heterotaxy and how different each one can behave. And we think that fundamentally that patient-specific variability, when it's a matter of millimeters of whether you impact the conduction system or not, they may be absolutely critical. So to try to better address this, we established the intraoperative surgical EP program in 2020. And this is a multidisciplinary team at Boston Children's that includes electrophysiologists, cardiac surgeons, as well as our colleagues from the engineering group, that are all working together to try to better understand this and to make take a different approach to how we approach EP in the operating room. And fundamentally, what we thought to do was, rather than relying on simply some of the rules from before, looking at can we just look at the electrical system in action in the operating room. We use a EP catheter. This is a commercially available catheter, which the electrophysiologists in the room may be familiar with, an HD grid, but any sort of orientation like this may work. that allows for easy localization of signals in multi-directions in the operating room. And it's a little bit like playing a game of Battleship, where we call out coordinates between where we're seeing the conduction system on our end of things on the EP side of the table and where the surgeons are looking at the catheter on the heart. On our end, what we're looking for is the His bundle electrogram, which on this intraoperative electrogram that we obtained sits in between the atrial electrogram lined up with the P wave and the ventricular electrogram. And it's this high frequency deflection that's our best way of sort of looking electrophysiologically at the signal from the AV node. I'll let Dr. Feins continue from here.
So we'll start with what the process is in the operating room and how we do the mapping, and then we'll talk a little bit about some of the data. So the initial components of the operation are like any other open heart surgery. We cannulate aortic by cable cannulation, typically have a vent in place and go on bypass. We typically will have patients maintain at mild hypothermia at about 32 degrees centigrade, and then we'll induce ventricular fibrillation to prevent any ejection from the heart. At that point, we'll open the heart with an atriotomy and often a ventriculotomy as well, and then place drop suckers from the bypass circuit across the AV valves to completely empty out the heart and prevent any competency of the AV valves so that the heart cannot eject. And with that all set up, we then defibrillate the heart back into sinus rhythm and then perform the conduction mapping with the catheter that Dr. DeWitt just showed. This process, the mapping itself, takes about 5 to 10 minutes, and then after that, we arrest the heart with cardioplegia and perform the repair as we normally would. I'm going to show a video now that really demonstrates the workflow within the operating room, really to emphasize the back and forth between surgery and EP as we're trying to localize where conduction is located. We typically will mark one side of the mapping catheter, which then allows for orientation of it. And then this is being placed inside the open, decompressed, beating heart, and where you may hear the exchange between surgery and EP. It's a little bit quiet, but we're basically placing the catheter inside the heart, asking where they're seeing it. The electrograms are being interpreted right in the operating room by the electrophysiologist, and we're sort of moving it over almost like a metal detector on the beach, trying to really zone in on where we're finding the conduction system, namely the His bundle potentials on the electrogram. And once we've really got a good idea of that, at that point, we'll often mark the heart as a reference point on the endocardial surface. And at this point, we're really trying to strategize how we're going to do the operation. A lot of what we're focusing on at this point is suture placement, patch placement, all with the eye toward avoiding injury to the conduction system. So we've been doing this for about 3.5 years now. We've mapped over 300 patients. About 60 patients have had heterotaxy syndrome, and in our last analysis of about almost 50 of these patients, we've seen a dramatic reduction in the rate of heart block after a biventricular repair in heterotaxy patients. So the historical controls in this particular cohort was 16%. You saw our published paper from a number of years ago was 14%. So nearly 1 in 5 patients were suffering heart block requiring a pacemaker. And in 3 years, we've only had 1 patient suffer heart block requiring a pacemaker. So it's been a dramatic reduction in the risk of heart block when performing biventricular repairs. We've also been, as shown before by Dr. Hoganson, you've been using the 3D patient-specific models, and we annotate every model with where we found conduction. And this is allowing us to essentially create a digital atlas of conduction anatomy and heterotaxy, which we hope can build upon the seminal works by Dr. Anderson and others who developed a lot of what we know about conduction anatomy. And now we're turning this into more of a dashboard, so something that you can actually use as a clinician in real time. This is showing on the left is the input where you can put in anatomic data to form a query. So if you wanted to look for a heterotaxy with asplenia, a balanced canal, double out right ventricle, what have we found in the patients we've mapped? Well, on the right side, you'll see we've mapped 7 patients that fit that criteria. And we then divide them up based upon where we found conduction relative to the VSD that a patient would have. And then in the right lower corner, you can see that the models for those 7 patients come up. and then you can even go into those models. And this provides a much more granular way of understanding conduction anatomy for these patients. So to conclude, we know that conduction anatomy in heterotaxy is variable and it's complex. Translating those schematics, those diagrams from the seminal histopathology studies to the intraoperative assessment is very challenging, and using conduction mapping helps to bridge the gap and guide surgical intervention. As I've shown, we have seen a notable reduction in the rate of heart block following biventricular repair in heterotaxy patients, and integration of the 3D heart models is allowing us to improve our understanding of conduction anatomy in the heterotaxy population. Thank you.
All right. Fantastic. And the second talk in this session is going to be with Dr. Feins again and Beroukhim, who's a pediatric cardiologist on the imaging faculty at Boston Children's, and she specializes in echocardiography, cardiac MRI, and CT. She's the medical director for the Complex Biventricular Repair Program, along with Ram Mamani, who's the surgical director, and she's also the co-director of the Heart Tumors Program. And her clinical and academic interest included ways to understand and improve the core outcomes of these patients with complex congenital heart disease, particularly those in the biventricular repair spectrum. So they're going to share with you about our biventricular repair program.
Thanks so much, and it's a real pleasure to be up here today speaking to you. And the title is 2V or not 2V? That is the question, and that is often the question in our patients with heterotaxy syndrome. Many of them have unbalanced AV canal defects, and we're wondering if we can perform a biventricular repair. And so what we thought we would do for this 10 minutes is to review a case, and much like we would in our weekly Complex Biventricular Repair Conference, I'll present the case, and then we'll have a brief discussion about the patient, how we think about them, and whether or not we should move forward with a Fontan versus a complex biventricular repair. So, hey, Eric, what do you think about my patient? This is an 11-month-old child with heterotaxy syndrome. He has asplenia syndrome, complex heart disease that I'll describe in a minute. Also a history of intestinal issues, intestinal non-rotation, who has had intestinal surgery, complications of that surgery, who is also NG tube fed, and also incidentally has oculocutaneous albinism. This child has had a 3D model, so had a cardiac MRI with 3D modeling performed, has dextrocardia with bilateral SVCs, so right and left SVCs to the ipsilateral right and left atria, has essentially looped ventricles with the right ventricle anterior, the left ventricle being posterior, and has pulmonary atresia with RV origin of the aorta. So essentially like a double outlet right ventricle with pulmonary atresia. The IVC is right-sided, and that goes towards that drains into the left ventricle. And as a palliative procedure, this child has had a central shunt. And if you look to the diagram on the right, the heart is spun around. You can see that this is a right dominant AV canal defect with a hypoplastic left ventricle. So moving to some of the cine imaging here, on this image on the left, you can see that there indeed is a right dominant AV canal defect with a common AV valve. There are two papillary muscles with a mural leaflet. However, you can see that the so-called left AV valve or mitral inflow is quite small. And by echocardiography, you can see that there is mild to moderate AV valve regurgitation. And then looking at this long axis picture on the right, you can see that the aorta is really quite remote and originates from the right ventricle, but it's pretty remote from the left ventricle. So moving on to volumetric data, you can see that the left ventricular end diastolic volume index is pretty small, 34 mLs per meter squared. And just for reference, for an infant of that age, it should be around 60, 70 mLs per meter squared. So it's about half the size of a normal left ventricle with normal ejection fraction, and the right ventricle is dilated with a normal ejection fraction. And further imaging, looking at the pulmonary venous anatomy, you can see that there is right lower pulmonary vein compression as it courses over the descending aorta. And by differential pulmonary blood flow, you can see that there's diminished flow to the right lung, likely associated with the pulmonary venous compression on the right. So, Eric, with this patient, as a cardiologist, I'm thinking, what should we do? Should we do single ventricle palliation, or should we move forward with a biventricular repair? When I think about this child, he has heterotaxy syndrome, which is a risk factor in the leading up to a Fontan. He has an unbalanced AV canal with a common AV valve, bilateral SVCs, and also pulmonary vein compression and stenosis. On the other hand, this seems like it would be a really complex surgery. There's a hypoplastic left ventricle. This is potentially a very long bypass time with, the potential for residual lesions, and also the fact that this child has pulmonary atresia, so he would need an RV to PA conduit and require further conduit replacements in the future. So, what are your thoughts about this child?
Thanks, Rebecca. So, we titled this talk, "To Be or Not to Be," that is the question. But when we have these patients presented in our weekly biventricular repair conference, we really boil it down, I think, to two questions. One is, can we achieve a biventricular circulation? And two is, should we try to achieve a biventricular circulation? So to the first question, a lot of these are anatomic and image-guided decisions or data that we're using to make decisions. What does the AV valve complex look like? Obviously, in unbalanced canals, we do tend to have more technical leeway in terms of cheating on to, for example, the right side of the AV valve complex to improve the left AV valve inflow. What does the ventricular mass look like? How big is the left ventricle? Is it something that can handle a full cardiac output immediately? Would it require staging? Is it something that we don't think is feasible? And also, especially in the complex heterotaxy heart, what is the feasibility of a baffle pathway? Oftentimes we are able to baffle left ventricle to the aorta, but the feasibility of that is highly variable. So I think the first question when we're looking at the data in a new patient is, can we achieve a septation? And then the second question, which I think boils down to some of it is the feasibility, but also the risk factors, is should we? And I think that's really where the Fontan risk factors for a particular patient guide a lot of the decision-making. Our motivation and what we're willing to do to achieve septation, I think, is much greater in patients like this who have multiple risk factors for a successful for having a Fontan, namely pulmonary vein stenosis, heterotaxy, pulmonary artery hypoplasia is another issue, and AV valve regurgitation, which we all know is a significant risk factor for single ventricle palliation.
So, in some of these kids, we decide to do a single stage biventricular repair. And in some kids, we feel like the left ventricle is a little too small and we have to go ahead and recruit the left ventricle. So occasionally, this is an example actually of a child who with Down syndrome and a right dominant AV canal who started out with an LV and diastolic volume of 18 mLs per meter squared, and it was felt to be too small for a single stage biventricular repair. So the staging operation included the placement of a BT shunt with a fenestrated patch between the branch pulmonary arteries, and that has the effect of increasing pulmonary blood flow. And then a fenestrated atrial patch is placed to encourage more flow into the left ventricle and allow for recruitment of the left ventricle. And in this particular patient who has again, a fairly small left AV valve inflow, a partial VSD patch was also placed to allow for growth of the left ventricle. And you can see that it grew to 46 mLs per meter squared. This child actually had a biventricular repair last week and has done quite well. So Eric, how do you think about with our 11-month-old patient, would you plan to go ahead and stage, or would you go for a single stage biventricular repair?
So the advantage to staging, there's advantages and disadvantages to both. If it was obvious, then there wouldn't be a dinner symposium about it. But the advantage to staging a procedure is twofold. One is, especially in the heterotaxy population, to do a complete biventricular repair often is a very complex, long operation. And as the clinicians, we have to make a decision of whether we think a child can handle all of this surgery in one shot. So one of the advantages of the staging procedure is that you can kind of break that up. You're breaking your cross-country trip up into legs rather than trying to do it the whole shot. Obviously, the disadvantage is you're committing a child to multiple operations, but on the other hand, if they're smaller operations, maybe that's the safer way to go. The second is how sure we are that the heart can, even if you could snap your fingers and do the surgery in an hour, whether the heart can tolerate being septated in one stage. And that's the other advantage to recruitment. You can gradually load the left ventricle, in the case of a right dominant canal, for example, and you can do this in a more gradual fashion, which I think can be oftentimes better tolerated by the heart. But also it allows you to understand how the heart's responding to recruitment maneuvers. In this particular patient, staging is not totally free either. You have a child with pulmonary vein stenosis. You have, right now, he's a shunted circulation. So, if you're going to stage it, you're either going to upsize his shunt and leave him as a shunted circulation, which we all know is not a perfect situation, or, you'd be committed to doing a Glenn and leaving the shunt with pulmonary vein stenosis that you may repair. There's some with AV valve regurgitation. So there's no perfect solution here. Nothing is without any risk, but I think those are some of the factors that we would think about in terms of whether we decide to recruit a patient and stage it or do a complete biventricular repair in one shot.
So that concludes this part of the talk. We do review outside cases all the time, so for second opinions, please feel free to reach out to us. Thanks.
They were very, very timely, so I think we have time for a couple questions if anybody questions about BIV repair or surgical EP mapping.
Hi, I have a question for the first presenters. I'm Shannon East from Delaware. Have you encountered any situations where you're doing the intraoperative mapping and you've had to change the surgical strategy, like you haven't been able to do a biventricular repair because of the location of the conduction system?
It's rare that we completely pivot and abort a biventricular repair. We will often, with the knowledge of where conduction is located, we can try to, skirt the edges and acknowledge that there is still some risk that we're going to injure conduction. There are certain anatomies that we've started to venture into with septation, the double inlet ventricles, where, that's earlier in its life cycle, in the stages of doing that. And in those cases, if the location of conduction on top of, AV valve anatomy makes ventricular septation for a double inlet ventricle particularly complicated, then in those cases we have, aborted the septation. So in that sense, the conduction location sort of is one more log on the fire to say, maybe this isn't the right heart to be septating.
Thank you.
Is Mike Epstein. I'm an electrophysiologist. This question is for Dr. DeWitt. So first of all, I want to say the reduction in postoperative heart block, very, very impressive. I mean, those are very impressive numbers. As far as your atlas of anatomy is concerned, are you routinely looking for alternate conduction systems, second conduction systems in these patients, or only based on preoperative suspicion, based on their anatomy or their preoperative electrophysiology?
Yeah, I would say that pretty much for any patient who's undergoing a biventricular repair, we are offering mapping to the surgeon who's performing the operation, and the vast majority of them we go ahead and map. Certainly for patients where we're anticipating who have heterotaxy, where we suspect that they may have twin nodes, we're going to look for multiple His bundles in different locations. And I would say it's fairly routine for the surgeons to look both along the VSD if present, and also up underneath the outflow tracts where we might expect the anterior node to be. So pretty comprehensive that we would look for both. We've found a few. I would say it's not as often as we expect to, which when you go back to those papers, you see that a lot of times that second node isn't connected down below. So probably why we don't get a His bundle, even though the node.
That's why I wanted to ask next. If you did find two AV nodes or two His bundles, would you then go and try to map the infrahissian conduction, looking for left and right bundle branch potentials associated with both AV nodes?
I would say it depends a little bit on what what's going to work best for the operation and what the surgeon is trying to navigate from an anatomic standpoint. So if, for example, there's an obstructing muscle bundle superiorly and there's a node there, they might be a little bit, if we know that there's one inferior that is also functional, we might go ahead and map the distal bundles there. Not quite as routine that we find ourselves in that situation, but we certainly have gone deeper down and tried to get a sense of kind of as you dive into the fascicles, kind of where those are running. But yeah.
The other thing we've done, and when we've found dual AV nodes, is we've atrially paced patients to see, if you can pace them faster or not, and that kind of has given us a sense as to, which node is going to be more reliable, if you will. That's my surgeon way of saying it, but that can be helpful in sort of the overall intraoperative risk assessment. The common scenario is the L-Luke patient with sub-PS LVOT obstruction, and how aggressive you want to get with with resecting muscle underneath the pulmonary or what would be a neo-aortic valve. If you know that they have a sling and they have an inferior node that works well, then your ability to open up the LV outflow tract is a little bit better.
Thank you.